Welcome to this deep dive. We've designed this session specifically for you, navigating your OB nursing course. Think of it as our focused look at some really crucial knowledge around common newborn conditions. We'll be covering respiratory challenges, the effects of gestational diabetes, hyperbilirubinemia, and also birth injuries. We've pulled together key information from various sources, aiming to give you a solid understanding for your nursing studies.
Exactly. The goal here is to sort of cut through the noise, highlight the core concepts you really need. It's about strengthening that foundational knowledge so you feel confident and clear when you encounter these situations.
Okay, great. Let's jump straight into respiratory issues in newborns then. This is an area where, spotting things early is just so critical. Let's start with respiratory distress syndrome, RDS. What's the main thing we need to understand here?
Well, the fundamental issue with RDS is immature lung development. You see it mainly in preterm infants. Their lungs just haven't produced enough surfactant yet.
Surfactant, right.
And surfactant is absolutely key. It lowers surface tension in the tiny air sacs, the alveoli, and stops them from collapsing when the baby breathes out. Without enough of it, breathing becomes incredibly hard work.
So it's not just about the lungs being generally underdeveloped, it's specifically that lack of surfactant.
Precisely. I mean, structural immaturity is part of it, sure, but the surfactant deficiency really drives the problem. The alveoli collapse, gas exchanges poor, and all that effort to breathe can actually cause more problems, like fluid buildup, pulmonary edema.
Okay. And risks beyond just being preterm.
Definitely. Things like perinatal asphyxia, lack of oxygen around birth, having a C-section without going into labor, being male, and maternal diabetes can all increase the risk. Knowing these helps us anticipate who might need, closer watching right from the start.
Makes sense. Okay, moving to transient tachypnea of the newborn, TTN. The name itself suggests something temporary, with fast breathing.
That's right. With TTN, you get this mild respiratory distress, rapid breathing, basically because the fluid that's normally in the baby's lungs before birth hasn't cleared out quickly enough.
So the lungs are kind of still a bit waterlogged.
That's a really good way to think about it, yeah.
Yeah.
The baby breathes faster, trying to compensate. The good news, though, is that TTN typically resolves by itself in, a day or two.
And risk factors, similar to RDS.
Somewhat similar, yes.
Yeah.
Being male, being large or small for gestational age, and again, perinatal asphyxia are noted risks for TTN as well.
Okay. Now, meconium aspiration syndrome, MAS. This sounds like something happening before birth has consequences after.
Exactly. MAS usually affects full-term and post-term babies. It happens when the baby passes meconium, that first stool, while still in the womb. This often happens if the baby is under stress, experiencing hypoxia. Then, if the baby inhales that meconium-stained amniotic fluid, it can cause pretty significant lung problems after birth.
And it's not just about physically blocking the airways, is it? Our sources mention a few different ways meconium causes trouble.
Absolutely right. It's sort of a triple threat. First, the thick meconium can literally plug up the small airways. Second, it can actually inactivate surfactant, making things even harder for the lungs. And third, meconium is irritating. It causes a chemical inflammation, a pneumonitis in the lung tissue itself.
Wow. Okay. And factors that might lead to meconium passage in utero.
Several things. Being post-term is a big one. Also, fetal hypoxia, issues with the placenta, low amniotic fluid, preeclampsia or maternal hypertension, even maternal smoking or cocaine use, or infections like chorioamnionitis. Recognizing those risks beforehand means the delivery team can be better prepared.
Very important. All right, persistent pulmonary hypertension of the newborn, PPHN. This sounds like a failure in how the baby's circulation adapts after birth.
That's exactly it. With PPHN, the baby's circulatory system doesn't make that crucial switch. Normally, the blood vessels in the lungs relax after birth to let blood flow through for oxygenation. In PPHN, they stay constricted, clamped down. This causes really high pressure in the pulmonary arteries.
So blood bypasses the lungs?
Right, gets shunted away from the lungs, leading to severe hypoxemia, low oxygen, and acidemia. It's like the circulation is still stuck in fetal mode.
And this isn't tied to just one cause?
No, it's most common in full-term infants, and it can be idiopathic, meaning we don't know the exact cause, or it can be a complication of other things we've discussed. Things like asphyxia, MAS, pneumonia, sepsis, RDS, or even a congenital diaphragmatic hernia. There's also some association noted with mothers taking SSRI antidepressants late in pregnancy.
Interesting link. Okay, and lastly for respiratory, just briefly, bronchopulmonary dysplasia, BPD. also called chronic lung disease.
Yeah, BPD is a chronic lung issue. It mainly affects preterm infants who've needed oxygen support for a prolonged period, usually defined as needing oxygen still at 28 days of life or beyond. It results from a combination of factors: the initial prematurity, lung injury from oxygen exposure, maybe mechanical ventilation, all disrupting normal lung growth and development.
Okay, that gives us a really good overview of the key respiratory challenges. Let's switch gears now and talk about the impact maternal diabetes can have on the newborn. We know this can set off a whole cascade of potential issues.
It absolutely can. Infants of diabetic mothers, or IMDs, are definitely at higher risk for several complications. The big ones are hypoglycemia, low blood sugar, and congenital anomalies.
Right, the congenital anomalies are a major concern. Are there specific types that are more common?
Yes, there's a higher incidence of major birth defects, especially if the mother's diabetes wasn't well controlled, particularly early in pregnancy, like in the first trimester. We most commonly see cardiovascular defects, heart problems, and central nervous system anomalies. But other systems can be affected too. It really highlights why preconception counseling and type blood sugar control during pregnancy are so vital for women with diabetes.
We often hear about these babies being quite large, macrosomic, but sometimes they can be small. Can you clarify that?
That's a good point. So typically the extra glucose from the mother crosses the placenta. This makes the fetus produce more insulin. This fetal hyperinsulinism acts almost like a growth hormone, leading to macrosomia, a large for gestational age, or LGA baby, often over 4 kilograms, or about 8 pounds, 13 ounces.
Okay.
However, if the mother has long-standing diabetes, perhaps with vascular complications affecting the placenta, then blood flow might be reduced. In those cases, you might actually see an infant who is small for gestational age, or SGA. But regardless of size, LGA or SGA, these infants can often be physiologically immature. They might look big and robust, but metabolically they can be quite fragile.
So that fetal hyperinsulinism is really central to many of the problems we see.
It's definitely a key driver. That high glucose level from mom stimulates the baby's pancreas to pump out lots of insulin. Great for growth in utero, maybe too much growth. But then after birth, that high glucose supply from the placenta is suddenly cut off. The baby's insulin levels are still high, though. That mismatch high insulin, no more high glucose supply, is what leads directly to neonatal hypoglycemia.
And it's not just about blood sugar, is it? The sources mention other metabolic issues, too.
That's correct. Besides the hypoglycemia and the risks associated with being LGA, like shoulder dystocia during birth, potential birth injury, asphyxia IMDs are also prone to other things. We worry about electrolyte imbalances like hypocalcemia and hypomagnesemia. These can cause jitteriness or even seizures. They can also develop polycythemia, too many red blood cells, partly due to chronic low oxygen levels in utero, and hyperbilirubinemia, or jaundice, is more common too. That's often due to the breakdown of those extra red blood cells, plus maybe more bruising from a difficult birth. Oh, and there's also a noted higher risk of hypospadias in male infants born to diabetic mothers.
It really paints a picture of needing very close monitoring for these newborns right from delivery. Okay, let's move on to hyperbilirubinemia, jaundice. It feels like almost every newborn gets a little jaundiced. What's the basic issue?
Well, at its simplest, hyperbilirubinemia just means there's too much bilirubin in the blood. Specifically, a total serum bilirubin, or TSB, level above 5 milligrams per deciliter. And that excess bilirubin is what deposits in the tissues and gives that yellow color to the skin and eyes that's jaundice.
And why are newborns, so susceptible to this?
There are a couple of main reasons. First, newborns naturally break down red blood cells faster than adults. Their fetal red blood cells have a shorter lifespan. This breakdown process releases bilirubin. Second, the newborn's liver, which is supposed to process that bilirubin and get rid of it, is still immature. It's not working at full capacity yet.
Like its processing plant is still ramping up operationally.
Exactly. So you have increased production of bilirubin and decreased elimination, leading to a buildup.
Okay. And since we see it so often, what factors might push a newborn towards having significantly high bilirubin levels? What puts them at higher risk?
Yes, several things can increase the risk. Any bruising from birth, like a cephalohematoma, releases more bilirubin as the blood breaks down. Prematurity is a big factor because the liver is even more immature. Having a sibling who had significant jaundice is a risk factor too. Insufficient breastfeeding in the early days can contribute, leading to dehydration and less stooling to excrete bilirubin.
Okay.
Then there are things like ABO or RH, blood group incompatibility between mom and baby, leading to faster red cell breakdown hemolysis. Polycythemia, which we mentioned with IMDs, also means more red cells to break down. Certain conditions like Down syndrome, family history of hemolytic disorders, maternal diabetes leading to an LGA baby, and even just being male are associated with higher risk.
That's quite a list. It emphasizes why we need to assess for these factors. Now, we often hear about unconjugated versus conjugated bilirubin. What's the critical difference we need to grasp?
The key difference really is toxicity and solubility. Unconjugated bilirubin, sometimes called indirect bilirubin, is fat-soluble. Because it's fat-soluble, it can cross the blood-brain barrier if levels get too high, and that's what can cause potential brain damage, neurotoxicity.
Okay, that's the dangerous one.
Right. Conjugated bilirubin, or direct bilirubin, is the form that the liver has processed. It's made it water-soluble. This form is non-toxic and can be excreted from the body in bile and urine.
Got it. And what about physiological jaundice? That's the type we sort of expect, right?
Yes, physiological jaundice is considered a normal process. It's that transient rise in unconjugated bilirubin that happens in most newborns. It typically doesn't appear until after the first 24 hours of life. It usually peaks around day 3 or 4, with levels generally staying below 15 milli-GDL, and then it gradually resolves over the first week or two. Encouraging early and frequent breastfeeding is important here, as it helps promote stooling, which gets rid of bilirubin.
But obviously, sometimes it goes beyond physiological. When does it become a concern, something pathological that needs intervention?
Right, it becomes a significant concern or pathological when the bilirubin level rises too high too quickly. We use specific charts, nomograms, based on the baby's age in hours. If the TSB level plots above the 95th percentile on that chart, that's significant. Also, if the level's rising very fast, say more than 5 milli-GDL in a 24-hour period, or more than 0.2 milli-GDL per hour, that's a red flag. And a TSB level reaching 25 milli-GDL or higher is considered severe hyperbilirubinemia. That carries a real risk of what we call bilirubin-induced neurotoxicity, or bind.
Bind. That's the serious outcome we're trying to prevent, sometimes called kernicterus. What happens there?
Exactly. Bind, or kernicterus in its chronic form, occurs when that unconjugated bilirubin crosses the blood-brain barrier and deposits in specific areas of the brain, particularly the basal ganglia. This deposition causes permanent neurological damage, leading to problems like cerebral palsy, hearing loss, and developmental issues.
And certain babies are at higher risk for bind, even at lower TSD levels.
Yes. Factors like prematurity, low albumin levels in the blood albumin normally binds to bilirubin and keeps it in the bloodstream. Hemolytic disease like from ABOR incompatibility, certain enzyme deficiencies like G6PD, sepsis, or just general instability in the newborn can increase the brain's vulnerability to bilirubin toxicity.
It really highlights why careful assessment, tracking those levels, and intervening appropriately based on guidelines is so crucial. Okay, last major topic, birth injuries. Thankfully, less common with C-sections, but they still happen. How do we define a birth injury?
Broadly, a birth injury is any kind of physical harm or impairment to the baby's structure or function that happens because of adverse events during the labor and delivery process. And you're right, while rates have declined, they haven't disappeared, and they can range from quite minor things to much more serious issues.
What are the kinds of forces during birth that can actually cause these injuries?
We'll think about the journey. There's compression as the baby moves through the birth canal. There's the force of the uterine contractions pushing the baby down. There can be twisting or torque as the baby rotates to fit through the pelvis. And sometimes traction or pulling is needed if delivery requires assistance. Any of these forces, especially if labor is very long or very fast, or if there's a mismatch between the baby's size and the mother's pelvis, cephalopelvic disproportion, or if instruments like forceps or a vacuum are used, can potentially lead to injury.
Makes sense. What are some of the more common types of birth injuries we might actually see?
Fractures are one type. The clavicle or collarbone is actually the most commonly fractured bone during birth. You often see that with breech deliveries or shoulder dystocia where the shoulder gets stuck, or just with very large babies. Fractures of the long bones, like the humerus in the arm or the femur in the leg, can happen too, but they're less common. Nerve injuries are another important category. Brachial plexus injuries affect the network of nerves supplying the arm. Erb palsy involves the upper part of the plexus, affecting shoulder and upper arm movement. Klumpke palsy affects the lower plexus, impacting the hand. These are often associated with large babies, shoulder dystocia, or breech births.
And cranial nerves.
Yes, trauma to the cranial nerves can happen too. Facial nerve palsy is probably the most common, where one side of the face droops. It can be caused by pressure, perhaps from forceps, or even just the way the baby was positioned in the uterus.
What about head trauma specifically?
Head injuries range quite a bit. We often see things like cephalohematoma, that's a collection of blood under the periosteum, the membrane covering the skull bone. doesn't cross suture lines, or caput succedaneum, which is more just
Yeah.
soft tissue swelling of the scalp, edema, that does cross suture lines and usually resolves quickly. More severe, but thankfully rarer, head trauma could include things like depressed skull fractures or intracranial hemorrhages bleeding inside the skull.
So it sounds like really knowing the details of the labor and delivery and then doing a thorough newborn exam are key to picking up on these potential injuries.
Absolutely. Reviewing the maternal and fetal history, understanding what happened during labor and birth, where there are risk factors like prolonged labor, abnormal presentation, instrumentation. That's crucial context. Then, a careful head-to-toe physical exam and a good neurological assessment of the newborn right after birth are essential for early detection and getting the right management in place if an injury is found.
This has been incredibly helpful, really drilling down into these key newborn conditions. Understanding the why behind respiratory issues, the wide-ranging impact of maternal diabetes, the nuances of hyperbilirubinemia, and the possibility of birth injuries, it's all so fundamental for providing safe, effective nursing care in OB.
It really is.
Yeah.
And it's good to remember that transition from intrauterine to extrauterine life is just a massive physiological shift for the newborn. Your assessment skills, your understanding of these potential bumps in the road, they made a huge difference to the health and well-being of these tiny patients and, of course, their families.
Absolutely. So maybe a final thought for you to take away as you continue your studies. Consider how your ability to spot those early signs combined with this foundational knowledge can truly change outcomes for newborns and provide that vital support for families navigating a really critical time. We definitely encourage you to keep exploring these areas. Thanks so much for joining us for this deep dive.